All right, so hopefully, Scott, we're good on the volume right now. So if anybody can't hear me, go ahead and type in or. So what we're going to do, I want to really preface what inspired me to do this presentation. Kinetic chain patterns and M.P.S.SCAR release therapy for complicated shoulder conditions. And what I want to talk about is that when you just treat a shoulder and you don't treat ascending syndromes like an overpronating or supinating foot, you don't treat sacral torsions, you don't treat all the joints of the body. Basically, a lot of times these complicated shoulders are complicated. So I'm going to feed off of, I know that you guys had Kelly Armstrong yesterday, and she talked about M.P.S. scar tissue. That's going to be a vital part of this presentation. I'm going to feed off that. And so what happened is I was in Kuwait in October of last year. I was treating a frozen shoulder for a very prominent family in Kuwait based on the request of their physiotherapist. And just doing shoulder work, I only got the shoulder from about here to about here. So I backed up and I've studied total body lymphatic drainage and some of the total body balancing with Dr. Carrie D'Ambrosia. And I started to blend the work of Carrie D'Ambrosia with the work of Eric Dalton, muscular alignment techniques. And I knew I had to look at the whole body because the patient had one foot supinating, one pronating, which was causing the pelvis to rotate around the lumbar spine. The patient had a tibial torsion. They had not a functional, but an anatomical leg length discrepancy. The patient had a roto-scoliosis of the lumbar spine, a kyphosis of the thoracic spine, fixated OA joint, spinal stenosis of the neck. So this is definitely a total body treatment. And so what I had to do is back up after the first session, come back in. They also had a scar from a supraspinatus tear, so I could not get the humeral head to drop. And Kelly has mentioned the microcurrent, the Dolphin M.P.S. microcurrent. Had I not used the protocol for the frozen shoulders and the rotator cuff injuries, I would not have gotten that humeral head to drop. And that was instrumental in changing this. And later on, I'll talk, if you notice in the upper left-hand side of my logo, it says Better Together as One. The Better Together as One Learning Academy, I approached Margaret Wallace Duffy last year and said, you know, I really want to work. She asked me in September at the conference, do you want to get all your stuff online? And because this is like an 18-hour course that we're trying to overview in an hour today, and in an hour of hands-on or 2 hours of hands-on next September, we put together an online course on steroids, which is really like taking chunks and pieces of this and taking test questions and having time to be online with me. So I'm going to go through the presentation format. So complicated shoulder conditions. So oftentimes what happens when we get a shoulder injury, let's go back to the MPS for a second. I had a pretty aggressive cycling accident about a month ago, and that's my leg on the left-hand slide. And the moment I got out of the emergency room and started to do microcurrent on that scar, so that treatment you're seeing on the left-hand side started right out of it after I got out of the emergency room and got those sutures, those staples and stitches put in my leg. The other picture you're seeing is my hip replacement, and between MPS release and myofascial cupping, the scar that is really nasty turned into a scar that's like a pencil line. And because of that, I'm able to do everything possible with my hip. In fact, using the MPS and the cupping on my hip actually allowed me to be able to teach a class, total hip replacement. I was teaching a class with 90 people, live seminar, no crutches, no pain meds. So what I've done is taken this and treated all the scars through the body. And I want to bring that into this presentation today. But if you really want an expert who is in my DVD in the online course, is Kelly Armstrong. Actually, we flew her to Dallas to co-shoot this online course that I'm going to be doing with Margaret Wallace Duffy and Fern, who they are in the Better Together as One booth right now if you want to contact them. So what we're going to talk about today, and I'm just going to move the screen over just a little bit. We're going to talk about today is the participant will list major muscle groups and anatomical landmarks involved in complicated orthopedic conditions of the shoulder. They will also understand the biomechanics of the foot. As you know, the foot has about 26 bones. And if that foot collapses and it doesn't spring back up and those bones don't lift back up, or if that fibular head isn't gliding when you're contacting closed kinetic chain patterns of the foot, And say, let's just say the foot overpronates. If the foot overpronates, it's going to cause internal tibial torsion. It can cause femoral torsion, iliosacral torsions, and that can end up as a shoulder problem. The expert was on yesterday, total body balancing, Kerry D'Ambrosia. Can't say enough about that amazing man, about his total body balancing, his total body lymphatic. Kerry is definitely a mentor to me, and therapists will be introduced to total body balancing to look at lines of tension throughout the body in this presentation. But Kerry is the master of that work, and he's been in the conference. He'll be in the September conference. We had a chance to hang out when we co-taught in Australia. So I'm going to barely introduce, and I don't do anything pure. There's a blend of Eric Dalton's work with joint function and the total body before we get into the shoulder. In states, provinces, and countries that approve microcurrent therapy, participants will be introduced to the dolphin microcurrent. I briefly talked about that for scars, but also when you're working on a complicated shoulder adhesive capsulitis, what's happening is the sympathetic stress is upregulated. So we need to calm down the nervous system so that the patient can take a deep breath and relax. So we'll be talking about that for sympathetic regulation versus parasympathetic, calming people down. Participants will also be able to thoroughly treat conditions such as rotator cuff injuries. I had a second-degree tear of my supraspinatus about 2 years ago from a mountain biking accident. And I could only move my shoulder like this and like this the next morning. But due to the cryoderm occlusion strapping, due to the microcurrent, due to everything that can treat that scar at a cellular level, I'm now raising my shoulder and have full range of motion and no restrictions. And had I had surgery, there would have been an additional scar, and I may have ended up staying in that position that I was in the first 24 hours. So we'll talk about the rehabilitation of rotator cuff injuries, secondary scars, upregulated sympathetic stress, secondary muscle guarding, and I've changed a lot what I'm doing to joint capsular patterns of the shoulders and hips. So we'll be able to look at rotator cuff injury, shoulder impingement, bursitis, pec minor tendinosis, bicipital tendinosis, rhomboid pain due to weak inhibited scapular stabilizers, nerve compression patterns that happen between scalenes, clavicular patterns, first, second rib patterns. We'll get into those conditions of the shoulder. So I'm going to go forward into the presentation. In the closed kinetic chain, if you have them weight bear, if you look at the first image on the left, you should be able to swipe 2 fingers on under the arch, unless the arch is collapsing and staying collapsed, which is going to cause articular ligament referral pain patterns, posterior tibial stress patterns, and it's going to cause soft tissue problems of the foot. So we need to evaluate the stirrup spring system. Are the bones lifting when you come out of the weight-bearing position? Is there a high arch? Is there a dropped arch? Is there a flat foot? Do they have pins cavus, or what's going on with the foot? Because that'll affect what happens to the joints above, the knee, the iliums, the spine, the back, and the neck. So we really need to check the foundation of the foot in both open and closed kinetic chain patterns of the foot and ankle. Now I noticed that they were doing a little bit of the pelvic floor work, but this is really a spin-off of Kerry D'Ambrosia's work I got from the total body lymphatic drainage class, as well as Eric Dalton's work. And when you gently compress and traction the ankle, you should see the kinetic chain moving all the way up into the head. In other words, the head should be moving as you gently push and pull in that leg. If you evaluate external rotation and clockwise circumduction, there may not be any restrictions. But if you evaluate the point of the hip on internal rotation and clockwise circumduction, a lot of the times, as we saw in the last presentation, that medial rotation of the hip can be lost, and it can be a hard infield. It can be a capsular pattern. We're going to talk about that in the presentation. Now, for capsular patterns, I want to reference a study that pertains to shoulder capsules and hip capsules. And I think our friend Aubrey Going is on there. So Aubrey knows John Sharkey very well in Dublin, Ireland. John Sharkey is an anatomist who has dissected bodies for, I believe, approximately 22 years. He wrote a paper that when he dissected patients that were diagnosed while they were alive with adhesive capsulitis or frozen shoulder, that most of those patients, most of them had been misdiagnosed by their doctor when they were alive. That most of those patients had scars, say a supraspinatus tear, say a pec minor's tear, say a bicipital strain, and upregulated sympathetic stress. So they had soft tissue injuries adhering to the capsule, and it mimicked the same restrictions of a shoulder as an advanced stage frozen shoulder. So due to his paper that he published based on, so what he did according to his paper that he published was every time someone was diagnosed with frozen shoulder, he would dissect them. And he found that most of them, again, had scars, which would lead to secondary muscle guarding, which would upregulate sympathetic stress. So the way we address hip capsular patterns and the way we address shoulder patterns now that have hard infills is we do a lot more positional release, find that place of comfort. We do a lot more gentle rocking to down-regulate the upregulated sympathetic stress so that we can reduce secondary muscle guarding around hips and shoulder patterns. So think about my hip replacement. There's a scar in there. Although my hip can move, and I'll show you when we get to the big screen here, in all ranges of motion. I forget which hip was replaced due to the microcurrent, due to the cupping, due to the early onset scar tissue remodeling. I have a prehab, rehab and rehab course just on hip replacements now. If you look at the positions of the ilium, the AIIS, which a lot of people have been talking about, or the ASIS, we want to look at things like iliosacral torsions. We want to look at things like rotated pelvis, which usually comes from one foot pronating and one supinating. We want to look at things like iliosacral upslips, because if we got an upslip, that's going to block movement through the kinetic chain, and it's going to affect shoulder, neck, and spine problems. So we're going to be checking the ASIS, and it coincides with the PSIS. If the ilium is anterior and inferior, if you study some of the work of Jocelyn Oliver, when the ilium is anterior and inferior, it weakens the psoas on that same side, and it inhibits firing of the glutes on that same side. So now we got to do some muscle testing to assure what's happening to the pelvis. So what we're going to do, and I learned this from an osteopath in Scotland. I was teaching an osteopathic conference in Scotland. And what the osteopath said, he said, Jim, if you outflare the iliums and inflare the iliums, outflare, inflare. So when we outflare, we can actually relax ligaments, inflare, mild stretch of the articular ligament. That sort of opens the gate around the sacrum to allow us to better and gently treat iliosacral torsion patterns, which if there's an iliosacral torsion, there's an unlevel sacral base, which leads to bulging, herniations, ruptures. So we got to get the spinal engine working. We got to get the sacral base level. But that's going to affect everything. An unlevel sacral base will cause bulging disc, herniated disc, ruptured disc, lumbar roto-scoliosis, ascending kyphosis, and scoliosis. So we've got to get the legs even and the hips even so that everything above that can be level on a level sacral base. One of the things if Aubrey's joining us, he was talking about this in a recent post or a recent webinar. Eric Dalton says that the knee is the slave to the hip and the foot. So if you don't get the hip and foot right, the knee pain is going to be chronic. But the number one thing at the knee is usually an external tibial torsion. When you drive your car, your foot has to turn out, which means the tibia externally rotates. And when the tibia externally rotates, what it does is it tracks the patella. It twists the ligaments. It shears the meniscus. And again, it ascends into the back, spine, neck, and shoulder. And so one of the things we'll be correcting as we look at the joints of the body is we'll be correcting tibial torsion. Short-headed biceps femoris is the culprit. Fibular head is twisted. Fibular nerve is sometimes compressed. So correcting tibial torsion, and the image in the first image on the left shows the assessment. The next image shows the correction of the tibial torsion in the supine position. The third image shows an assessment for external tibial torsion in the prone position and a correction of the tibial torsion. So basically what we have to do to further up the kinetic chain patterns, we have to balance the femur with the tibia so that nothing's twisted in the knee. And these are simple, 1 minute, simple assess, correct patterns. Now the ankle The joint functions of the ankle should be dorsiflexion, plantarflexion, inversion, eversion. A lot of the time we'll get a sprained ankle and we'll have a subtalar joint problem. And what holds the bones together are ligaments. When the talus slides out, the ligaments refer, it upregulates secondary muscle guarding. So we're going to be showing you in the presentation at the Canadian Massage Conference in September 25th weekend, some corrections for subtalar joint shears. We're going to show you what we're going to do to the bones of the foot to get better ankle function. Remember, that's the foundation of the entire kinetic chain. So we'll look at those 26 bones of the foot and look at which ones are not lined up, which ones are not lifting after you spring off that closed kinetic chain pattern, and we'll reduce what's called ascending syndromes that are things happening in their foot that work their way into the knee, back, spine, neck, and thus into the shoulder too. Now, common things of the shoulder, when we get to the shoulder, if there's a hard infill on external rotation, again, that's usually a capsular restriction, as well as maybe a strain, as well as an upregulated sympathetic stress. So we're going to be doing some positional release techniques, which you see in the second image. Just relax the shoulder, do some gentle rocking, and then stabilize the scapula and stretch the shoulder. We won't be going in and doing the mortar and pestle thing like we did last year and the year before at the Canadian Massage Conference, due to the clinical studies of John Sharkey talking about scars, upregulated sympathetic stress, and secondary muscle guarding, and will help to move that. And then Eric Dalton, when I was assisting him last July 4th, not this past July, but the one before, he said to treat thoracic outlet, shoulder impingement, and shoulder bursitis, we must massage the middle deltoid and decompress the humeral head. So the middle deltoid actually wraps around the scapula, and it comes around like this. And when it's tight, it pulls at the tibial tuberosity and it compresses the humeral head into the supraspinatus tendon, which also irritates the subacromial bursa. So when we work on middle deltoid and we web around it, we can drop the humeral head, which will help with bursitis. It will help with shoulder impingement, which is supraspinatus impingement, and it will help better treat adhesive capsular patterns and secondary scars of the shoulder. So we're going to be getting into some of those techniques in the shoulder. We're also going to look at the neck. Now, this is all before we do the actual shoulder work. Rotation restrictions, the SCMs. So if we have a hard infill, it's usually occiput compressing C1 into C2. So the SCMs, they don't flex the head and neck. The SCMs extend the occiput and then they drive the neck forward. So the SCMs actually don't just attach at the mastoid process, they wrap around the suboccipitals. So when I was teaching at Northwestern University Chiropractic College, we dissected the SCM and we thought from massage school that it attached to the mastoid process. But it actually doesn't. It continues around the occiput, and what the SCM does is it extends the occiput and then drives these vertebral C1 with C6 through C3 stack on their anterior to their inferior neighbor. So we're going to show you how to work the SCMs and the suboccipitals to decompress the occiput from C1 so it can better rotate over C2. And then we'll stretch those suboccipitals, which are just from C2 to the occiput. I had a chiropractor in my class this weekend in Tampa at the 5-day intensive just this past weekend. And he said, why didn't we learn how to treat those suboccipitals and those SCMs? Why didn't we learn how to do a technique that stretches the suboccipitals to free up C1 so it can freely rotate over C2 without any forceful or high velocity manipulations being necessary? Now, stretch the hip capsule. So the first image is an anterior capsule. When we barely lift the knee and press the femoral head into the table, we're actually stretching the iliofemoral ligament, we're stretching the upper fibers of rectus fem, and we're stretching the anterior capsule. By doing that, we further free up the femur, from the ilium, so that the femur, when you raise the femur, it's not dragging the ilium anterior and inferior. So by doing the technique in the first image on the left, we're stretching the fascial adhesion in the anterior capsule. We're stretching the iliofemoral ligament, which attaches the ilium to the femur, and that frees up the femur so it can move freer and more independent of the ilium to prevent things like iliosacral torsion patterns. And then we'll check muscle firing patterns on hip extension. When someone extends their leg or brings it up off that massage table, the hamstring should fire, then the glute max, then the opposite QL, same side QL. Sadly, the glutes become inhibited because I'm sitting right now. And as I sit, my brain is telling my hip flexors to engage and my glutes to inhibit. If I sleep in flexion, I'm getting inhibition of glute max. So what ends up happening is the QLs get upregulated. So if the hip extension isn't coming from primarily hamstrings and glutes, glute max, then it's coming from QL and the rectus spinae, which means we have a world full of lumbar spine compression, spinal stenosis, bulging disc, herniated disc, ruptured discs. So what we do if the glutes aren't activated is we put them under a stretch and we do spindle cell. We can do the figure 4 like I learned from Eric Dalton and drop the knee off the table, or we can just put the foot off the table and roll the femur internally, which puts glute max under a stretch and activate the glutes. So that when you stand up, it's coming from glutes and hamstrings instead of from hamstrings, QL, erector spinae. These are all things that affect the kinetic chain that if we don't check these things out, by the time we get to the shoulder, all kinds of patterns are going on in the shoulder. Here we have an assessment of the PSIS. I try to keep this simple. Whatever we do to the AIIS, we do to the PSIS. So we have left ilium, right ilium, sacrum. If there's an anterior right or posterior left, the sacrum goes unlevel. If we outflare in the front, we relax the ligaments in the back. So we can do this and allow that, but if they're prone, like you're seeing here, we can assess on the second image, you see a high PSIS, which means an unlevel sacral base. To correct it, you can just go under that rotated ilium, stabilize the opposite PSIS, and just take that iliosacral torsion out. If we don't take the iliosacral torsion out, we can't activate the glutes because of the law of reciprocal inhibition. When the ilium rotates forward, the glutes become inhibited. So we'll correct iliosacral torsion patterns. Most of these, before we get into the shoulder, are going to be 1 to 2 minute techniques, most of these. We'll decompress the lumbar spine with some pelvic tilts. We'll check internal and external rotation of the hip to see if there's any hard infills, bone-on-bone like infills. A hard infill is when you're trying to stretch, say, piriformis, and it goes maybe 20 degrees instead of 45 of internal femoral rotation. Slide number 2 says internal rotation should be 45, but it also should be soft. So if you have a hard infill, you may have a scar that's causing upregulated sympathetic stress. You may have secondary muscle guarding. You may have a lot of things going on, and stretching is going to actually further upregulate sympathetic stress. But again, if you can hit the scar with the microcurrent and you can relax the capsule, which is inside the joint, and do some rocking and relax the secondary muscle guarding, it will soften those infills, and then you can balance out the internal and external hip rotators. And again, this is about a minute or 2 technique. Then we'll check, once we've checked the ankles, the knees, the hips, the shoulders, the neck, the elbow, wrist, and hand, then we'll check range of motion of the shoulder. So active range of motion is performed by the client. So we'll just say, flex your shoulder. And if it's restricted, we'll start to do the math. What might be stopping that motion? Extend your shoulder. If they compensate or if they have pain with movement, we'll further evaluate the ligaments, the bones, the nerves, and scars. Abduction, sometimes they'll only go to like 160 and there'll be a springy block infield, which indicates an impinged supraspinatus tendon. Adduction across the midline, internal rotation should be 90 to 100. But sometimes when you do that, if there's a capsular pattern, it causes the ligaments to refer in the front of the shoulder. External rotation, one of the very first things you lose in your shoulder is you lose external rotation because we live in medial rotation. The early onset capsular patterns is when that becomes a hard infill instead of a soft infill. We'll also do we'll check for end-feel on passive assessment. When you try to just passively rotate the shoulder, hard or soft. Hard needs positional release. It needs some rocking to shut down upregulated sympathetic stress and secondary muscle guarding. Abduction may be springy. And if you have an impinged supraspinatus, think about releasing the capsule, releasing the middle deltoid, dropping the humeral head, and stretching pec minor so that you can have full range of motion of that shoulder. So we're going to show you some simple, quick, easy, effective corrections of shoulder impingement. Muscle testing is very important because it identifies, there's a lot of things can hurt in front of the shoulder. Subscap will be tight and can cause restrictions. Biceps, coracobrachialis, short, long head of the biceps. We can have the clavicle impinging the subclavius artery and brachial plexus of nerves. We can have scalenes causing tight and elevated fixated first rib patterns for thoracic outlet. So if we don't evaluate for strains, which is a scar, which is tearing of muscle tendon fibers, we don't know where it's coming from. So what I do is I test subscap, I test the biceps coracobrachialis complex, I test the pec minor for a strain, I test the supraspinatus, which is the fourth image across. I check the infraspinatus and teres minor. So again, I mentioned I had a second-degree tear of my supraspinatus from a mountain biking accident. Due to the microcurrent, I'm able to get the humeral head off of that injured muscle. And sometimes instead of doing multi-directional friction into a scar and concentric and eccentric loading, all you need to do is microcurrent followed by movement. And movement becomes concentric and eccentric. So the nice thing about the microcurrent is it breaks it down at the cellular level. It goes into increasing ATP, blood and oxygen, and changes the consistency in the matrix of the scar at the deepest level. So if you look at the capsular adhesions on the very first image on the left, there can be adhesions inside the capsule, but there are also, back to John Sharkey's clinical study from Dublin, Ireland, there can be a supraspinatus scar. So if you think about a supraspinatus tear, here's the acromion, here's the supraspinatus, here's where it's impinged, and this tear is going to be right under there. So when I went to Kuwait, I couldn't get the lady's shoulder was doing this because of the supraspinatus tear. It actually caused guarding and it caused a humeral scapular adhesion. No matter how much I worked that middle deltoid and dropped that humeral head, it wouldn't drop because of the scar under it. And I physically could not get my fingers in there, and I couldn't get the scar out from under the acromion. So that's when I came back and hit that with the microcurrent. I did a pass around the shoulder. This is all in the DVD that I did with Kelly Armstrong, that the online course I'm going to talk about at the end with the Better Together as One group. Better Together as One Academy is going to be, we treat the scar. So Kelly's actually in my video doing the scar treatment for rotator cuff injuries, for adhesive capsulitis. And if I hadn't learned that before going to Kuwait, I would have never gotten that person's shoulder, that humeral head to drop and that shoulder completed. So I'm a big advocate on M.P.S.SCAR release therapy. But I'm also a big advocate of taking the upregulated stress and doing positional release and waiting for the patient to relax and then doing some traction. So if you just gently compress the humeral head and relax the capsule, then do some rocking to relax the upregulated secondary muscle guarding and stress, and then just stretch the capsule and pull fluid into it and treat the scars with the microcurrent, you're going to get some amazing results beyond your imagination, beyond anything you've ever seen. Paul Kelly said something really brilliant today in his presentation. Paul is a good friend of mine. I've been with him many times in Eric Dalton's seminars. He said, what we say has a profound effect on the psycho-emotional part of pain. What we say has a big effect on whether they're going to heal. So many of my colleagues say it's impossible to release from shoulder. I'm glad I didn't believe them because they're not up in the research. In fact, the doctor in Kuwait who runs the #1 shoulder conference in the world, which I've been invited to, I was supposed to be there September 25th of this year, but because of COVID, I won't be in Canada or there. And he said that across the world, probably 50% of shoulder surgery should not be being performed. based on the work I'm sharing in this class. And he said, when you do soft tissue repair, you shouldn't be immobilizing shoulders because those secondary scars will lead to secondary adhesive capsulitis patterns. So many of the US physicians, in fact, when I went in for my injury, I had already rehabbed it. I already had the humeral head dropping. I was in the pool doing concentric and eccentric loading. So I walk into the doctor's office like this. And then when he saw the MRI that showed the second degree tear, he said, you need to have surgery. And I'm like, but doc, I'm moving like this. And he said, we need to mobilize your shoulder. I said, doc, but I showed him the video when the next morning it was like this. And if I'd immobilized it, it would have been worse. And sadly, that particular surgeon in America asked me to leave his office. So I did, because he didn't want to look at the research. He didn't believe in the M.P.S.SCAR release. He didn't believe in he didn't believe a lot of things. And basically, I bet his textbook in medical school was at least 5 years old. So it was outdated. So he didn't have this new research in it. So we have to be careful what the doctor says to the patient versus what we say to the patient. You know what? I'm going to facilitate a healthy shoulder. I'm going to treat the joints. I'm going to treat the ligaments. I'm going to treat the scars. I'm going to balance the muscles. I'm going to pretty much put your shoulder back where it belongs and get everything healthy. And the body then has the innate wisdom to heal itself through movement. Movement is the key. Paul Kelly also said that in his presentation today. Movement is the key. Belief systems are the key. Determination is the key. And good manual therapy assists us into getting those joints healthy enough for movement to be done pain-free. Now, if you look at the slides over there, this follows, Paul Kelly also mentioned Vladimir Janda, upper cross syndrome. Because of the world we live in on computers and doing massage, doing chiropractic, doing osteopathic work, we tend to have forward shoulders, rounded shoulders. And due to the SCMs, we tend to have this occiput extended back in this neck forward. And so we have to reverse those patterns. We have to get a healthy neck to get healthy nerves. We have to get a normal cervical curve. But in the shoulder, we should start working on what Yonda said was tight. Pec major, pec minor, subclavius. We need to release the anterior deltoid and drop the humeral head a little bit. We need to make sure that there's functional clavicular motion where when you're raising your arm, the clavicle is dropping down into the sternal notch. We have to determine whether the clavicle needs stability or mobility based on testing. We have to rule out the Eden's test, which means the clavicle is compressing the first and second ribs, causing compression of the subclavius artery and the brachial plexus of nerves. And we're going to show you some simple user-friendly techniques to clear those clavicular rib patterns, to clear to allow the clavicle to drop into the sternal notch when you abduct so it can lift off the nerves and blood vessels. Now, if you look at the slide on the left, I do want to reference a good friend and colleague again, Eric Dalton. I missed this the first 5 times I studied with him. I think I've either studied with him or co-taught with him about 9 times over the last 12 to 15 years. But a couple years ago, I think he was actually at the Canadian Massage Conference when I picked on this one. He said, Jim, if you don't release middle deltoid and drop the humeral head, you can't treat thoracic outlet, bursitis, and shoulder impingement. So I spend a lot of time releasing upper traps, middle deltoid, especially middle deltoid, and decompressing the humeral head to allow the humeral head to be off of the supraspinatus tendon and the subacromial bursa. I really believe that therapists should do that, work middle deltoid and drop the humeral head before they stretch pec minor. Now, when you stretch pec minor and you put it under a stretch and they pull against resistance, it's called a muscle resistance test. If they pull against resistance and there's a muscle strain, it's only going to get worse if you don't get that scar healthy. Again, we can do a combination of microcurrent, we can do multidirectional frictioning, but we have to follow with concentric and eccentric muscle contraction because according to the research of Drs. Cook and Kahn, dating back tendinosis research from 1990, the only thing that actually reorganizes scar tissue is movement. So whether we hit it with the microcurrent or we hit it with multidirectional frictioning, we have to move it concentrically and eccentrically to realign that scar tissue. And then once it's healthy and there's not a capsular lesion and there's not guarding, then we can stretch pec minor which frees up the pathway of the brachial plexus of nerves and the subclavius artery to help with thoracic outlet conditions. Again, what you're seeing is not just the capsule on that first image on the left, but the surrounding muscles. The surrounding muscles. So by these teaching models, say to your patient, you know, in the front, there's the subscap. That's right behind your rib cage. On the top of your shoulder, there's the supraspinatus. A lot of time it gets impinged on the acromion, especially if there's tight traps in middle deltoid, tight pec minor. Impingement is common, and they can't raise past here, so they get used to doing this. But impingement will show you a fast and easy 2-minute protocol to treat shoulder impingement. You'll release the capsule, which is the image on the second screen. Just positional release, relax the capsule. Then do some gentle rocking to relax secondary muscle guarding, then stretch the capsule. Pull fluid into it. Then what we'll do is we'll check the clavicle out. Is it moving properly at both the sternal and clavicular joint? Is it lifting off the nerves when you abduct your shoulder? Is the medial clavicle dropping down into the sternal notch of the sternum when abduction or forward motion of the shoulder happens? The next slide is one of my favorites. I was teaching a workshop in Westport, Ireland, close to where Aubrey is. Aubrey Going, who's in this presentation, going to be at the conference. I'm glad Aubrey's joining us in September at the conference. It's good to see him today in the social media interaction we have. But one of the osteopaths, he was from London. He came to Westport, Ireland, and he said, young man, if you don't know how to get the breath right and get the first and second rib right, you will never treat TOS, thoracic outlet. So he was in my class, and he loved the shoulder work, the hip capsule work, the shoulder capsule work. He loved that. So he said, I'll train you how to do scaling work correctly, how to get the ribs right. And so he got me on the table, and what he did is he elevated the clavicle, which is in the third slide in the middle of this presentation. Then what he did is he found my first rib, like you're seeing in the fourth slide, found the first rib. And then what he did is he had me take a deep breath, and on deep inhalation, the rib came up, the rib comes up. But on exhalation, you could feel the rib dropping, and he would drag the rib down on forced exhalation. And so when you're taking a deep breath, the lungs are expanding, the scalenes are lifting, so the ribs are coming up. Let that happen. But on the exhale, what we're going to be doing in the hands-on part is we're going to get under that clavicle, get on that first rib, and on the exhale, the forced exhale, we're going to drop the rib, and then we're going to stretch middle scalene and anterior scalene. So I used to go in and scrub the heck out of the scalenes and strip through the scalenes, and I only upregulated the stress they were already under. I used to do something else wrong. I used to stretch middle scalene like this and anterior scalene like this, and actually it made my thoracic outlet worse about 15 years ago. So again, I learned to get the clavicular motion functional. I learned that we're going to teach you how to grab that first rib. I learned that on forced exhalation, when the rib's dropping, that's when you move the head and stretch the scalenes from both ends to free up. If you look above my fingers, there's the brachial plexus of nerves between the intermiddle scalene. So if we do the breath work and we do the decompression on the forced exhale and only move the head when the rib is dropping, then we can treat TOS. If you've performed the ASIS test for nerve tests, the ASIS test is indicative of this technique being necessary. And then we stretch those scalenes on forced exhalation. Sideline, so I was when I was working in Kuwait on the frozen shoulder, I was evaluating external rotation, and the physio was great, but the physiotherapist, one of the other guys observing, was going, work subscap, work subscap. And I said, I don't really need to work subscap if I release the traps, I release the lats, and I do positional release of the shoulder capsule. And he was kind of baffled because he's used to going in and treating subscap, serratus anterior. So we're going to show you in this class, and I'm going to demonstrate at the end of the presentation on Fran, this particular series of techniques. Hard infill and external rotation of the forearm. So subscap, it's more than just a tight subscap. It's a capsular lesion, early onset capsular adhesion, secondary muscle guarding, and a possible strain of a muscle. we're going to show you how to do, if you look at the fourth slide from the left, we're going to show you how to do positional release of the capsule and gentle rock. Which they're going to, oftentimes the patient will take this deep breath and go, especially if you've already done the occlusion strapping with cryoderm, the dolphin work, they're more likely to go and just let that shoulder go. And then we're going to do the move that you see in the fifth slide, and that's going to drop the humeral head. If we do this series of techniques that I'm going to demonstrate as a teaser of what you're going to learn in hands-on in September, you can really do magic with advanced stage frozen shoulder patterns with this particular series of techniques. This is the favorite part in all of my presentations. And this course, by the way, has never, ever been taught anywhere in the world. I just developed it in October. The Together as One Learning Academy approached me to put it online with them. When COVID happened, I called them up and go, you know what, I need to get online. I need to make a course that's like an online course on steroids where they can do small chunks. They don't have to go out of the safety of their home. The expense is 1/3 of a 3-day class that would take them 3 days to learn the content that we've got in this online course that I'll talk about at the end. And all of these PowerPoints are in there along with about oh gosh, it's like 3,000 step-by-step, bulleted step-by-step protocols and colored photos to take you through this whole series. And I'll talk about that at the end of the presentation. Quite an amazing course. So I'm going to go to the next slide here, and let's move this out of the way. There we go. Triceps. One of the nerve tests we do for ulnar nerve entrapment in the cubital tunnel is we put the tricep under a stretch and we tap. And if it refers along the ulna or into the little finger and ring finger, you have an entrapped ulnar nerve, which could come from fixated ulnar humeral condyle, come from articular ligaments. It could come from a scarring of the muscles that attach there. So what I'm getting at is putting the triceps under a stretch irritates it. So what we want to do in manual therapy is lengthen the biceps because they're short and strong, and relax and strengthen the triceps to rebalance out the antagonist. What we want to do in the back is we want to relax the infraspinatus and teres minor, as you're seeing in the second image. And we want to relax those rhomboids and that they have a forward thoracic curve where they're forward in their thoracic spine. We want to push those erector spinae back up under the spine so that they can activate good closure of the thoracic facet joints when we have them arch their back. So if you release the horizontal diaphragms and you release the superficial front line, you still have to push the erector spinae back into the spine so they can help close those stuck open thoracic facet joints in people with thoracic kyphosis. And that's really important to get good rib function. That's important to get good diaphragmatic function. That's important to get the shoulder to work better. Also, when you downward rotate the scapula, as in the third image, what it does is it relaxes the rhomboids, it repositions the levator scapula. It really helps both the neck and the shoulder feel so much better. And again, in the fourth slide, we're decompressing the humeral head because we want to get it off of the subacromial bursa and the supraspinatus tendon. I'll do one more here. Let's go slide. Let's go down to this. Okay. So we're relaxing the posterior rotator cuff. We're doing a muscle resistance test. So in this case, friends, pointing to a strain in the infraspinatus tendon. We can do multi-directional frictioning and concentric and eccentric muscle contraction, or we can do microcurrent with the dolphin. So we have options on treating scars. I'm leaning more towards the microcurrent now than the frictioning. And those are muscles that we will strengthen in home care retraining. Okay, let me move this slide over a little bit so people can see me. There we go. And go to the next slide. So also scapular retraction, I was working with, there was an Olympic swimmer in one of my recent seminars, and he said, I'm having trouble getting my arm out of the water with enough power. What happens because we're working on computers and we're doing body work is our rhomboids often become weak and neurologically inhibited. So to pull the scapula back and get the arm out of the water becomes a weak activity. So if we check scapular rhomboid function or scapular retraction and it's limited, what we do, and again, I learned this from my colleague Eric Dalton, is we put the rhomboids under a stretch and we let the elbows fall forward on the table and we do muscle activation. It's called dynamic gamma motor neuron technique. So what I started to change with swimmers is I stopped having them stretch the rhomboids and I start having them stretch the pecs. Then I have them strengthen the rhomboids, but typically strengthening the rhomboids, you're only going to get about 60 to 70% of functional firing of the rhomboids unless we activate them. So we can do muscle activation with our hands. We can use things like the Mile Buddy to do percussion and vibration at 60 hertz. And then we can reassess scapular retraction. And you're going to see a huge change in the hands-on part of this when we activate those weak muscles in the back to bring that scapula towards the spine, to get that arm out of the water. And then we can do myofascial therapy to the rhomboid. Now, there's this whole series of exercises in our online course with the Better Together as One Learning Academy, way beyond what you're going to be seeing in this presentation. But at a minimum, you need to stretch pec minor, strengthen rhomboids. The technique in the third slide I developed while I was in Kuwait because her therapist was having her grab a weight and do circumduction, but the weight closes the kinetic chain. So if you put a Velcro brace around the wrist and then you do circumduction and just let the muscles all relax, sometimes it allows that humeral head to decompress a little bit. So simple corrective exercise. I love Paul Kelly's stuff. He talks about empowering the patient, motivating the patient, giving them an incentive. Don't tell the client you can fix their problem. That's the biggest lie in manual therapy. Basically, what we're going to do in this presentation in September is we're going to assess the ankles, knees, hip, ilium, spine, shoulders, elbows, wrists, neck for lines of tension, especially joint dysfunctional tension. We're then going to correct some of those patterns, quick and easy 1 and 2 minute techniques. And then what we're going to do is we're going to go through the shoulder and make sure the clavicle's right, the first and second ribs are right, the scalenes are right, pec minors are right, everything's balanced, and the shoulder's moving the way it's supposed to be moving. Rolf said one time, if you put the body back to where it belongs, the body has the innate wisdom to heal itself. So if we can get things healthy, if we can get the joints healthy, we can get the scars, which when you watch Kelly Armstrong in our Kinetic Chain Kinetic Chain Shoulder online course with the Better Together as One Learning Academy, she's the expert. She treats a C-section scar, and sometimes that gets rid of neck and shoulder, just the C-section. She talks about the research of the microcurrent, and this online course is quite amazing. With Kelly, I bring in my whole life. This was my goal. And let me go to the next slide and talk about it. As we know, this is what I miss about the 12 years I've been at the Canadian Massage Conference. This is another conference, but typically I used to have 80 and 90 at the Canadian Massage Conference. I think in San Diego, I probably had 130. I don't know, it was a huge class. But I'll have a bunch of teaching assistants and they come and interact with you. Right now, our classes numbers between now and next February, other than this coming weekend, right now they're between 5 and 10 people. And last weekend I had 2 of my top teaching assistants with me in Tampa. We had 6 people, including 2 chiropractors of those 6 in our class, and they loved it. The personal mentoring, the supervision, the guided imagery of how these things are done more effective. So between now and next February, if you do anything live with me, I'll tell you that basically you're going to have small, intimate groups with the same amount of big screens and images on the wall. And so the way I teach, I'm very visual and kinesthetic. So every technique, I'm going to reference Carrie D'Ambrosio, every technique you do should start and finish with assessment. And if we do that, then every next technique will be the right next technique. And that's the way I base treatments. The last slide I want to share before I do a demonstration with Fran. This was sometimes there's a wake-up call from me from God. There's this amazing thing that happened. So in September, I was with Scott and Monica and everybody at the Canadian Massage Conference, and Margaret Wallace Duffy said, Jim, we've got this vision that her and I both had our whole life, is bringing together leaders in the world of manual therapy. So I've done cruises with Eric Dalton. I've done cruises with Dr. Hyde, who's a chiropractor. I've done cruises with Aaron Mattis, world leader in kinesiotherapist. So over my 20 years, I've been able to train with masters of every field of manual therapy, from osteopaths to chiropractors to physical therapists, athletic trainers. And I thought this vision was mine until I read their mission statement. The Better Together as One Learning Academy, which I'm so honored and so grateful to be a part of, was a brainstorm of I believe, Margaret Wallace Duffy. Her and Fern and Monica and Scott called me and they said, Jim, are you ready now? So in COVID, everything shut down. March 12th, I had 15 major conferences, all canceled. I was going crazy. I called them back. In September, I said, no, I'm too busy. I called them back and I said, you know, you guys, I'm ready. I got to get my stuff streamlined. I got to get online set up, but I don't want your traditional online course. I want a course where they can watch a little section, take a test, and be reviewed. I want a course where they can interact with me once a month on Zoom to ask questions, review techniques. I want a course that's inexpensive, that gives CUs. But what I wanted to do on this kinetic chain pattern M.P.S. and SCAR release course is I wanted the 18-hour content to be taught by the masters. I brought in Kelly Armstrong, and it was mind-boggling what I learned from that woman, world leader in scar tissue release. And if it wasn't for her, I wouldn't have been successful in Kuwait releasing that advanced stage frozen shoulder. And when you fly halfway around the world, you're expected to get results. So this particular course has got, you don't have to go to the safety of your home. You don't have to go anywhere. You get CUs. You can watch it as many times as you want. The images from these PowerPoints are all built into your handouts. I have to say, we have a special right now. If you go to the vending hall, the room where you can go now for this conference, and you go to the Better Together as One Learning Academy, we've got a COVID special $225. Comes with all the video footage of everything that we shot professionally in a studio. It comes with all of the PowerPoints and the handout step-by-step protocols. It comes with your ability to watch Kelly live, treating a C-section scar, sharing all the research. Kelly live, treating a rotator cuff injury, frozen shoulder, showing all the research with the apps and the acupressure points and all those kinds of things. And honestly, we worked hours and hours and hours over 3 to 4 months. I think I'm the one that's blessed, because now we are bridging the gap in the world of manual therapy. So please go to the Better Together as One Learning Academy. They are in the vending hall right now. You can talk to Margaret or to Fern. Those women and Monica and Scott were such a blessing in my life. Beyond words will never tell you how important it was to guide me. That I didn't even know what Zoom was when I called them up in March of this year. I didn't know how to do a webinar. I didn't know any of this, and they walked me through without making me feel like I didn't know anything about social media. So God bless this group, Together as One Learning Academy. I am honored to be sharing that platform with not only this group that developed it, but with world leaders of people that have been in this conference, people like Harry D'Ambrosia, people like Kelly Armstrong, people like Eric Dalton. This platform is going to change the face of medicine. So please go visit that. And with that said, what I'm going to do is I'm going to say we also have my videos in our website, www.orthomassage.net. So my new nerve ones were just developed a couple years ago, kinetic chain knee one a couple years ago. But the best course, again, just so I can't say enough about it, is the new, I would call this e-learning course an e-learning course on steroids. It's something I've never imagined, the quality and the perfection and the hundreds of hours that were put into this course. So check it out. And in the meantime, I'm gonna get my wife in here and do a demonstration, just a teaser of what you're gonna be covering in September with the hands-on part of this course. So I'll stop sharing the screen and I'll get the table ready. And Scott, can I go full screen on this? So I'm full screen. I know your handsome RMT pictures in the middle of my screen. I don't know if it's on their screen or not, but or you can let me know, Scott, if we're full screen or not, if you want to unmute yourself, buddy. So I'll see if Scott can switch us to full screen. I want to give you at least a demo of one of the cutting edge things you can do for adhesive capsulitis, shoulder impingement, bursitis. It's probably my favorite technique of anything I've ever done. So let's see. Scott, are you there, buddy?
I am here, buddy. You look great. You're good.
Are we full screen?
Yeah, your view is just fine.
Awesome. I'm gonna bring my lovely wife Fran in here, is the one that keeps me on track, keeps me organized, keeps me.
She's a beauty.
She is a blessing, I have to admit. She's gonna come in here.
Up or down?
We're gonna do a sideline position. And I'm gonna bring the table really close so you can see this really close. Get my chair out of the way. You're gonna lie right here with your right shoulder up. So this is a preview of one of the great techniques that worked for me in Kuwait, and the supine capsular work that I've been demonstrating didn't get me results. So we're gonna say someone comes in with adhesive capsulitis or a frozen shoulder, they have a secondary scar, which, by the way, if you haven't seen the microcurrent, that go to Kelly Armstrong's booth, and we would do microcurrent first. But I want to show you something. When we assess external rotation, Fran has about maybe 45 degrees with a hard or bone-on-bone like ankle. Again, back to John Sharkey's clinical studies. Maybe there's a supraspinatus scar. In Kuwait there was. So if I didn't treat that with microcurrent first, this technique would be minimized. It would be effective, but minimized. So what we do when we find that hard infill is we don't go and work pecs and subscap and different muscles that will give us more motion here, because it's not a muscle pattern. It is literally a capsular pattern. What you're going to see is I'm going to relax Fran's shoulder, and I'm going to relax the secondary muscle guard. What you're going to see me do now is just relax the capsule, so my hands are coming together, and then again relaxing the secondary muscle guarding. Had I done the M.P.S. prior, which is in our online e-learning course, she would be much calmer. She would be like Scott. He has no stress. He's just totally like chilled out today, I can tell. But she'd be much calmer. And then what we'll do is we'll do this position like this that'll drop the humeral head from the acromion. Just really traction the capsule down. Now watch again. Now, taking into consideration the supraspinatus tear, when you go in, immediately shift the shoulder. And if there was corticoclavicular ligament, Robert Libby's work, articular ligament, good job in your book, Robert. If there was articular ligament referral pain patterns, actually shorten the ligaments. So bring the corticoclavicular joint and the clavicle here together. Now do some gentle rocking to get rid of upregulated sympathetic stress and secondary muscle guarding. Then decompress the humeral head. Then the best part is yet to come. Work the anterior deltoid to stretch the anterior capsule where the lesions tend to form. Then I'm going to give this last part credit to Eric Dalton. Work middle deltoid just with some petrosol. Once you work middle deltoid, what you're going to do is you're going to web above the acromion. So let me show you the teaching model in here because I'm used to using my toys. You've got the spine of the scapula, and you've got the acromion in your hand. Your webbing is going to be right above, lateral to that acromion to decompress that humeral head. So if I massage middle deltoid, find the acromion, go lateral to it, and then just decompress the humeral head like that, what that does is it drops the humeral head off the acromion. And then what that does, watch, if I just take Fran's little finger, she has full range of motion on external rotation. So 5 ounces of pressure, all it requires to stretch subscap. And now you don't have to physically work subscap because you have full range of motion back on the shoulder. Sorry, that was a cameo appearance by my rescue dog, the little mini purple. She wanted to be in the video, I guess, but she didn't. So positional release. Gentle rocking. Remember John Sharkey's paper. Scars, upregulated sympathetic stress, positional release for the strains and sprains, rocking for the secondary muscle guarding, decompress the humeral head, work the anterior deltoid. This is what got me the full results in Kuwait, which means I was able to meet with their surgeon. So I wanted to show you this now. Now we've got good range of motion here. We can better stretch out pec minor. We can reduce shoulder impingement. Thanks, Fran. Go ahead and say hi to everybody before you leave. Fran is so shy. Seriously, you guys know her when you meet her. So I want to finish with something, Scott. I want to say the reason I designed the online course with Better Together as One Learning Academy is that it relived what happened in Kuwait. They paid me a really hefty figure to come out to Kuwait and work on one of the top royalties in the country based on a physiotherapist that trained with me in Ireland. And when he came to Ireland, he said, I can't do his shoulders what James is going to do. You need to fly him out here. And I said, no, I didn't really want to go to Kuwait last October because I was busy, but I did. And what happened as a result of releasing the shoulder, I got to meet with her physio, he's certified in all of Gray Cook's work, Gary Gray's work. He's got his fellowship program. This guy's a master of bodywork. I got to meet with the physio, but the best thing that happened in this experience that triggered this presentation and that triggered the online course with the Better Together as One Learning Academy, the best thing that happened is I got to meet with the surgeon. And this surgeon is the top surgeon in the world for shoulders. And the surgeon said to me, he goes, Jim, our physios don't know how to do this kind of work. Otherwise, he said, I would be doing 50% less surgeries. And he said, across the world, about 50% of shoulder surgeries are being performed for financial reasons. They're not necessary. Like my secondary scar tissue of my supraspinatus. He said to me, we're on track. Would you come out to Kuwait? And it was supposed to be this September 25th. We've switched to next year. Would you come out and teach 300 surgeons from across the globe? Now, these are all shoulder surgeons. And what he wants me to teach is what we're doing in this course. He wants me to teach prehab and rehab and prevention of shoulder surgeries. Because he believes that surgeons across the globe are doing 50% unnecessary surgical procedures. And he knows when we get the clavicles right, the ribs right, the scar tissue with the microcurrent healthy, we free up the nerves. He saw the magic, and that was his patient that I treated. So we had dinner in Kuwait at a 7-star restaurant. He wined and dined me. He took care of me. Next year, I'll be going back to Kuwait, and they'll be getting the same presentation that you're going to get for the first time ever. You're going to get the live presentation. No one else has gotten this presentation. It's going to happen in September. You'll be getting it first. The surgeons will be getting it next year. And then the people in the US and across the globe will be getting it in 2021. So now that we have, we can be in the safety of our home doing these things. I also want to thank the Canadian Massage Conference. And honestly, God, and this tears me up almost. Scott and Monica and everybody in this organization, and Fern and Margaret Wallace Duffy, who I got to share the keynote speech with at the conference last year. They're like family to me, especially during this difficult time. They came together, they pulled me out of a rut. I'm now inspired to do online stuff, which we're going to do much more of. I want to thank the Canadian Massage Conference, which I have spoken at for the last 12 years. But I assure you, this group, you'll be seeing some techniques in September that you've never before seen in all of my presentations in Canada or across the globe. So I want to thank my friends, who I call my family, from the Canadian group. I'm so blessed to have this connection as we all come together for the best interest of medicine, and we all come together for the best interest of our patients' outcome. So Monica, Scott, thanks for this opportunity. Fern Wallace, thanks for being in this presentation, watching. I am so missing my Canadian friends. And Scott said I'm an honorary Canadian, but they won't let me across the border, so I don't know what's going on. But I love you guys, and I really look forward to the hands-on presentation. And you'll be the first in the world to get this live course in September. So tell your friends, share the word, share the Facebook post. Let's make this a global thing across the world, because they can be in the safety of their homes and learning how to change people's lives forever. So thank you, and God bless.